Chapter 24, Myeloproliferative Neoplasms. So we're going to start our journey with these types of pre-leukemic conditions. The myeloproliferative neoplasms are clonal hematopoietic disorders caused by genetic mutations in the hematopoietic stem cell. It results in expansion, excessive production, and accumulation of either red cells, white cells, and platelets. It is due to a hypersensitive or independence of normal cytokine regulation that reduces cytokine levels through negative feedback systems normally induced by mature cells. Expansion occurs in varying combinations in the bone marrow, peripheral blood, and tissues. The MPNs have pathogenic similarities as well as common clinical lab features. They present as stable chronic disorders that may transform first to a subacute, then to aggressive cellular growth phase, and can lead to acute myeloid types of leukemias or acute lymphoblastic leukemias. They may manifest a depleted cellular phase, such as bone marrow hypoplasia, or exhibit some clinical symptoms and patterns that are characteristics of subacute followed by more aggressive cellular expansion. The World Health Organization has classified these MPNs into categories based on their involved cell lines. The most commonly studied ones are chronic myelogenous leukemia, polycythemia vera, essential primary thrombocythemia, and primary myelofibrosis. There are several conditions that are less common and have been described, and they are chronic neutrophilic leukemia, as well as not otherwise specified types of leukemias, chronic eosinophilic leukemia, and mastocytosis. Now here are some differential features of myeloproliferative neoplasms. This is an excellent chart for you to study from for the exam because it distinguishes the lab characteristics involved in identifying these different types of MPNs. Myelogenous leukemia is an MPN arising from a single genetic translocation in the pluripotent hematopoietic stem cell, producing a clonal overproduction of the myeloid cell line, resulting in a lot of immature cells in the neutrophil cell line. It begins usually with a chronic clinical phase and, if left untreated, progresses to an accelerated phase in 3 to 4 years, which often terminates in acute leukemia or blast crisis. The clinical features are frequent infection, anemia, bleeding, and an enlarged spleen, all secondary to the massive pathological accumulation of myeloid progenitor cells in the bone marrow, peripheral blood, and extramedullary tissues. Neutrophilia with all maturation stages present, basophilia, eosinophilia, and often thrombocytosis can be noted in the peripheral blood. CML occurs at all ages, but is seen predominantly in those aged 46 to 53, and represents about 20% of all cases of leukemia, is slightly more common in females, and carries a mortality rate of about 1.5% per 100,000 cases. Symptoms are usually clinically onset with intensity of fatigue, decreased tolerance of exertion, anorexia, abdominal discomfort, weight loss, and symptomatic effects of spleen enlargement. There are dramatic morphological changes in the peripheral blood and bone marrow that reflect the expansion of the granulocyte pool, particularly in the later maturation stages. A dramatic shift to the left is noted that extends down to the promyelocyte stage and occasionally even produces a few blasts in the peripheral blood. The platelet count is often elevated, reflecting the myeloproliferative nature of the disease. You can have extramedullary granulocytosis as well, and that may involve other kinds of sinusoids, medullary cords in the spleen, and solid pieces of the liver, which results in an enlargement of the liver and a marked leukocytosis of over 100. Usually, if they catch it early, you can catch it around 25 to 75. And again, the earlier you catch it, depending on the phase of the disease that is occurring. Unique chromosome, the Philadelphia chromosome, is present in proliferating hematopoietic stem cells and their progeny in CML and must be identified to confirm the diagnosis. The Philadelphia chromosome is a reciprocal translocation between the long arms of chromosome 9 and 22. This acquired mutation specifically reflects the translocation of an ABL proto-oncogene band from chromosome 9 to the breakpoint cluster region, which is BCR, of band Q11 of chromosome 22. Now, this results in a unique chimeric gene called BCR-ABL1. This new gene produces a BCR-ABL fusion protein that expresses enhanced tyrosine kinase activity from the ABL moiety compared with its natural enzymatic counterpart. There is an intense hypercellularity that is present due to the granulopoiesis marked by those immature granulocytes within the bone marrow. Normal blasts appear reduced in number, and megakaryocytes are normal or increased in number, and when increased, can occur in clusters and exhibit some dyspoietic changes. They often appear small and reduced nuclear size. The presence of pseudo-Gaucher cells may also be present in this form in the bone marrow. And again, to ensure we have a CML crisis, even in blast crisis and accelerated form, you have to remain under 20% to consider this still a CML. Now let's talk about the transition of CML. Before blast transformation, some patients proceed through an intermediate or an accelerated phase. It's usually accompanied by an increase in the frequency and number of clinical symptoms, adverse changes in lab values, and poorer response to therapy than in the chronic phase. Additional chromosome abnormalities can reflect the evolution of the malignant clone and may appear associated with enhanced problems with cell maturation patterns, which increases in morphological and functional abnormalities in blood cells. There is an increasing degree of anemia in the peripheral blood. There tends to be fewer maturing leukocytes, more basophils, and fewer platelets, with a greater proportion of abnormal platelets the longer this disease progresses without treatment. Here you're going to get to a circulating blast count that increases from about 10 to 19%. This total percentage or accumulation has been proposed the diagnostic criterion for getting to the accelerated phase. The blast crisis involves the peripheral blood, bone marrow, and any kind of extramedullary tissues, and based on the acute leukemia definitions, blasts constitute more than 20% of the total bone marrow cellularity, and the peripheral blood exhibits increased blasts, and this usually requires or leads into the transformation of AML or ALL. The goal of therapy includes complete hematologic, cytogenetic, and molecular remission that is indicated by a normalized CBC and differential and the absence of the Philadelphia chromosome and that BCR-ABL fusion gene. There have been certain drugs that were introduced to decrease the tumor burden, such as interferon and other kinds of alkylating agents. Bone marrow and stem cell transplantation with either autologous or allogeneic stem cells have been reported as curative, especially in people under 55. But modern therapies involve the use of a synthetic protein that binds the abnormal BCR-ABL protein by blocking that tyrosine kinase activity and reducing the signal transduction activation. So here's what your clinical picture of your peripheral blood would look like. See many different stages of neutrophil maturation in addition to many types of increased basophil. The next MPN is chronic neutrophilic leukemia. It's a clonal disorder in which the hyperproliferation of neutrophilic cells in the bone marrow produces a sustained neutrophilia in the peripheral blood and an increased liver. So CNL here has to be differentiated from CML based on the absence of that Philadelphia chromosome and that BCR-ABL fusion gene, as well as from a reactive neutrophilic process. Now the incidence is not exactly known, but they have had patients that had some kind of chromosome abnormalities observed, particularly if this disease progresses, including additions of chromosome 8, 9, 21, or certain portions of deletions of chromosomes 20, 11, and 12. It's a rare disorder where patients have a white count of more than 25 with a slight shift to the left. Here, neutrophils will dominate, but the increase in bands, metamyelocytes, myelocytes, and pros in combination usually only compromise fewer than 5% of the white cells. Neutrophils don't appear dysplastic, but sometimes they have toxic granules. The bone marrow reflects the peripheral blood in that it is hypercellular, with predominantly the proliferation of neutrophils, including myelocytes, metamyelocytes, bands, and mature segmented neutrophils. The median age here is about 65 or older, affecting both males and females the same. For a diagnosis, the white count must be higher than 25 times 10 to the 9 per liter, with greater than 90% mature neutrophils, fewer than 10% immature, and fewer than 1% blasts in the peripheral blood. The bone marrow shows increase in normal appearing neutrophil cell lines with fewer than 5% myeloblasts. Splenomegaly must be present and is often accompanied by hepatomegaly. And reactive neutrophilia must be excluded by eliminating the causes of infection, inflammation, and any kind of tumor that causes neutrophilia. And most patients present with fatigue, weight loss, and bone pain. So CNL is a slow, smoldering condition, and patient survival ranges from as short as 6 months to longer than 20 years. The neutrophilia does progress, and some patients can develop a myelodysplasia, and some can even experience a transformation to AML. So some therapies of hydroxyurea would be the first line, and then other certain types of drugs like interferon would help the median survival. So here would be a clinical picture of CNL where you have over 90% mature neutrophils. Polycythemia vera is a neoplastic clonal myeloproliferative disorder that commonly manifests with panmyelosis in the bone marrow and increased red cells, white cells, and platelets in the peripheral blood. Enlarged spleen is common, and the disease arises from the hematopoietic stem cell. You're definitely going to have an increased red cell count and due to increased red cell mass. Now there needs to be a way to classify polycythemia. So on the left-hand side we have a normal whole blood sample when spun down should be 45% packed red cells and 55% plasma. When we have an absolute condition of polycythemia, you're looking at an increased cell mass resulting in a decreased type of plasma proportion. Now this is normal or decreased erythropoietin levels due to an uncontrolled cell proliferation. When we talk about secondary types of polycythemia or relative types of polycythemia, these are due to the same amount of red cell mass, just a decrease in the plasma volume, which could result in dehydration or other kinds of high altitudes or other kinds of genetic disorders. Hyperplasia often associated with PV suggests a clonal stem cell defect, and cytogenetic studies have confirmed its clonal in nature. Although all lineage of the peripheral blood can be increased, an increase in erythropoiesis is the outstanding feature and results from the increased proliferation of the unregulated neoplastic stem cells. Erythroid maturation is normal and the erythrocytes function normally with a normal lifespan. The specific JAK2 mutation, or JAK2V617F, is detected in 90 to 95% of these patients. This point mutation in the Janus kinase STAT pathway substitutes guanine with thymine at exon 14 of the gene, which changes the amino acid position 617 from valine to phenylalanine. This one amino acid change prevents the inhibition of tyrosine kinase, causing it to remain in the active conformation or always turned on. Now this mutation has also been identified in a couple other types of PMNs, such as essential thrombocythemia and primary myelofibrosis. Due to the high red cell mass, you can see that patients sometimes have plethora, which is a red ruddy complexion on their face. Now it goes into phases as well, which progresses to a spent phase in few patients. Here in this phase, patients experience progressive enlargement of the spleen or the liver, and then eventually pancytopenia. They may also exhibit the triad of bone marrow fibrosis, anemia, splenomegaly, and teardrop-shaped poikilocytes. The mean age is usually 40 to 60 years old and more frequent in males than females due to a natural phlebotomy every month. Now, there is major and minor criteria for the diagnosis of absolute polycythemia vera. The major criteria being hemoglobin must be over 18.5 grams per deciliter, and there must be a presence of some kind of JAK2 mutation. The minor criteria include a bone marrow biopsy specimen showing hypersensitivity with trilineage growth with prominent erythroid, granulocyte, and megakaryocyte proliferation. The serum EPO level must be below reference range or normal, and there must be endogenous erythroid colony formation in vitro. Treatment of choice for PV is a therapeutic phlebotomy at a frequency necessary to maintain the hematocrit at less than 45%. Low-dose aspirin has also been shown to minimize any thrombosis, and alkylating agents or chemotherapeutic agents have also been used to reduce any proliferating cells. There have been newer treatments or molecular targets that provide JAK inhibitors with patients and have found very good results. Now, secondary polycythemia can be caused due to some kind of increase in EPO resulting in tissue hypoxia. Now, this can either be a clinical condition or any kind of condition where you need more red cell production for tissue oxygenation. And here is just a picture of the peripheral blood. There's not too many outstanding or alarming things seen in the peripheral picture, but in the CBC report, you will definitely see that striking increase in your red cell hemoglobin and hematocrit counts. Essential thrombocythemia is a clonal MPN with increased megakaryopoiesis and thrombocytosis, usually with a count of greater than 600 and sometimes with a count of greater than 1,000. Now, because the diagnostic criteria states that there must be a sustained thrombocytosis with a platelet count of 450 times 10 to the 9 per liter or greater, the incidence or determining ET has been extremely difficult because the findings are similar to CML, primarily myelofibrosis, and polycythemia vera. The JAK2 V617F occurs in approximately 55% of patients with ET. It has been thought to be sensitive to tissue growth factor that leads to an increasing uncontrolled thrombopoiesis and decreased sensitivity to negative regulators. There could be some mutations in the thrombopoietic receptor, MPL. It's a rare condition, and the peak incidence in age is about 50 to 60 or 20 to 30 years old. In more than one half of these patients, the disorder is discovered in the lab unexpectedly due to an elevated platelet count on routine CBC. The remaining patients see a physician due to vascular occlusion or hemorrhage due to the increased platelet counts. Bleeding occurs most frequently from mucous membranes in the GI and upper respiratory tract, and the spleen is observed in about 50% of the patients. Now, with this, we must differentiate true essential thrombocythemia from a secondary or reactive process. So in order to do that, there are certain diagnostic criteria. The features include a platelet count or sustained platelet count of greater than 450, and a hemoglobin of less than 13, a normal erythrocyte mass, and stainable iron in the bone marrow, or a failure of iron therapy. Philadelphia chromosome has to be absent or negative, and there has to be an absence of bone marrow fibrosis, as exhibit a JAK2 or other kind of clonal mutation. So here is the diagnostic criteria based on the hue characteristics. Please study this for your exam. About 50% of the patients survive 5 years, and the prognosis is better in younger patients. The treatment involves prevention or early alleviation of hemorrhage or any kind of vaso-occlusive complications that occurs when platelet counts increase. The production of platelets must be reduced by suppressing marrow megakaryocyte production by things like alkylating agents like hydroxyurea. Now here is an image of an increased platelet count, and some of the times we can get giant or large platelets in the peripheral smear over time. Myelofibrosis, or an alternate name, chronic idiopathic myelofibrosis, or agnotic myelofibrosis, or fibrosis with myeloid metaplasia. This is a clonal MPN in which there is an enlarged spleen and an ineffective hematopoiesis associated with areas of the bone marrow, hypercellularity, fibrosis, and an increase in megakaryocytes. Myeloid fibrosis in this disease consists of increase in reticulin and collagen within the bone marrow. The increases of these collagens and reticulin are a secondary process due to the increased release of fibroblastic growth factors such as platelet-derived growth factor, transforming growth factor from megakaryocyte granules, tumor necrosis factor, and interleukin-1. Marrow fibrosis causes the expansion of the marrow sinuses and vascular volume and an increased rate of blood flow. Now, because of this excess fibrosis, the bone marrow is not able to make the proper cells it needs and results to extramedullary hematopoiesis processes. Now, as similar to PV and ET, the JAK2 V617F mutation is also involved here as a cause of primary myelofibrosis and is found in about 65% of patients. The disease occurs in patients older than 60 and may be asymptomatic, but primary myelofibrosis also generally presents with fatigue, weakness, shortness of breath, palpitations, weight loss, discomfort and pain in the left upper quadrant associated because of the enlarged spleen. Because of the fibrosis, there might be abnormalities in erythrocytes noted on the peripheral bloods as red cells try to squeeze out of fibrotic tissue, causing dicryocytes. The average survival after diagnosis is about 4 to 5 years, and the main causes of death include infection, hemorrhage, thrombosis, and cardiac failure. Now, some of these conditions can also convert to AML or sometimes ALL. There is no cure or specific treatment, but corticosteroids and androgens have been thought to be a supportive measure. Abnormalities in the red cells are noted on the peripheral blood films with the presence of dicryocytes or other bizarre shapes. You may see nucleated red cells and polychromasia. Granulocytes may be increased, normal, or decreased in number, depending on the phase of the disease. Platelets may be normal, increased, or decreased, with a mix of normal and abnormal morphological features. The bone marrow biopsy exhibit intense fibrosis, granulocytic and megakaryocytic hypercellularity, as well as dysmegakaryopoiesis and dysgranulopoiesis. Neutrophils may exhibit some impairment of physiological function, such as phagocytosis. And due to the variable findings, you might have an anemia also developing, depending on the degree of fibrosis present. So the bone marrow will have a difficult aspiration or a dry tap, varying degrees of fibrosis in an absence of the Philadelphia chromosome. So here is a clinical picture of the problems you can see due to primary myelofibrosis. As you can see, the platelets are large and abnormal in shape. You might see a dicryocyte or a few of those, and sometimes immature types of cells coming out. Now, MPNs in the category unclassifiable are designed to capture any kind of disorder that express myeloproliferative features but fail to meet the criteria of those specific conditions that were named earlier, or overlap with some of the symptoms. Some of these conditions include chronic eosinophilic leukemia, hypereosinophilia, and mastocytosis.